and welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Pod guests share their career-defining drug, song and book, and also share their joyful patient stories.
Welcome to the Oral Apothecary Podcast. My name is Jamie Hayes. For this episode, we're joined by Dr Catherine Labinjoh. Catherine is a general cardiologist in NHS Forth Valley, Scotland, and National Clinical Advisor to the Scottish Government for Realistic Medicine. We'll welcome Catherine in a moment as she shares a drug for our formulary, her career anthem, and recommends a book for the Oral Apothecary Library. Our micro-discussion this week will be informed by an article from the New Statesman by Dr Phil Whittaker. It's a case write-up about Ted and his relationship with his medicines. But first, let me welcome my two fellow apothecaries. They're back from Bordeaux. STC is in Bournemouth and Gimmo is in Cardiff.
Bonsoir.
Evening. Yeah, it was good, wasn't it? It was good. It was a good trip.
Have you recovered?
Well, as you can hear, I'm a bit croaky, so I apologise if my voice fails or I cough. So I'm recovering from a bout of man flu. I didn't get it in Bordeaux, but I don't think 3 days of drinking wine probably helped. But it was good. Good conference. We did a good live show, and I think it's always different doing it in front of a non-British audience. It's our second time, but I think they learned something. We learned something. It was good.
I was reflecting after we did it. You know, we always say that where there's medicines, there's memories. But we had two guests, Roberto Frontini, Italian, and who's late into his career, was retired now, actually, was a president of EHP, and a very young, feisty Spanish pharmacist called Beatriz Toroba. And the medicines that they gave us, it just showed you that one was a medicine that was a very sad story because it was somebody who had died, somebody that Roberto knew that had died due to heparin-induced thrombocytopenia. And then Beatrice's was a very happy story because she told about she had to keep ringing this doctor up who was prescribing the docetaxel chemotherapy wrong every time. And then she said, and now he's my husband. So that was pretty cool, I thought. And that wasn't planned. We don't plan any of this, do we? We like to take it live. So, Jane, what were your reflections?
Yeah, I was going to give a shout out to Roberto and Beatrice. I thought they were both great. Yeah, really enjoyed it. Really enjoyed the evening before. I think I spoke to about, more than a dozen different nationalities from around Europe and beyond. And so it was great. In particular, had some chats with some great people from Malta, France, Spain, all over the place. It was great. And that was the European nature of it. Really, really enjoyed it. So
we should say thank you, shouldn't we, to the European Association of Hospital Pharmacists who invited us out there. So thank you to them. And
we are available for Copenhagen next year.
Yeah, it's in the diary.
Jamie, I must just say one thing that you did say. There we are with our little pull-up that says Oral Apothecary, and then just us and a couple of microphones. And you said, we're like buskers, aren't we? We could just turn up, pull up the Oral Apothecary advertising hoardings, and then off we would go. We'd just get people off the street. Maybe that's another show there.
There's definitely another format there. But you know what? It's not us. It's the medicines and their stories, which are that's the bit, isn't it? Medicines
sure, of course.
Medicines are everywhere, and just tease out those stories from people. And so there we go. A few things from me. Look, we haven't done this for a while. Thanks for sending us your emails. Sorry we can't return any to you, but we will give a prize for those that we mention. There's a joke in there somewhere for those of a certain age. And I haven't done book club for a while, so I've got a book. It's Oops, Why Things Go Wrong, Understanding and Controlling Error by Niall Downey. Just finished it. He's a former cardiothoracic surgeon turned pilot. So you can imagine It's full of human factors. It's a great read.
Lacking in confidence?
It's a great read. And I saw it recommended by Dr. Brian Goldman, who I follow on X, Twitter, the Canadian physician. And yeah, wasn't disappointed. If you enjoy the human factors bit, and you will enjoy that.
Oh, can I just say, I have started reading Demon Copperhead, as per Tony Avery. I'm about a third of the way through. So I haven't got into the meat of the real problems, but it's really well written. I'm enjoying it. I'm not a massive reader of fiction, but I was trying to read it when we were in Bordeaux, but things got in the way, like food, talking, wine.
Very good. Let's move on. Let's welcome our guest. It's a great pleasure to welcome Dr. Catherine Labinjoh. Catherine graduated in medicine from Edinburgh University and worked across Scotland and later in rural Africa, where she became interested in developing multi-professional working, patient safety and health governance. She's a graduate of the Scottish Quality and Safety Fellowship Programme and current ambassador to the Quality Governance Collaborative at the Royal College of Physicians in Edinburgh. She's passionate about person-centred care and building and providing care and services based around patients and families. She's learning to speak Spanish and enjoys getting out into the Scottish hills on foot or by bike with husband Andy and dog Martha. Welcome to the podcast, Catherine.
Good evening. Hi, everyone.
Thank you for joining us. Look, you met Steve Edinburgh.
Edinburgh.
Yeah. What was that, Steve?
British Geriatric Society Conference. Yeah.
Yep.
And we met at the Scottish Practice Pharmacists and Prescribing Advisors Association Conference.
In Glasgow, not so long ago.
No, where I asked you, would you come on the podcast? You gave me a false email to start with, so that's very clever. Yeah, but our people,
it's just instinctive.
Our people tracked you down.
Apologies for that.
No.
We got you anyway.
Jamie's well known for stalking celebrities at conferences.
Yeah.
People like Sir Michael Marmot avoid him now as soon as he comes off stage.
Oh, golly. Yeah.
Yeah, Don Berwick is in my sights for a fortnight's time. He's in Cardiff in a fortnight, and so
fantastic.
I've got a strategy there.
Oh, he's a great storyteller, so yeah, you should capture him.
So, Catherine, storytelling and medicines, if we bumped into you in a pub, in a coffee shop, in the hills, and we said, explain realistic medicine to us, where would that take us?
It's a good question. I'm asked it often, partly where does it come from? What does it mean? What's its relevance? So I often start by saying that realistic medicines is not a new invention, although it's something that's championed by the Scottish government. It's not something that was created by government. It's really a reflection of what people who were providing care and those who were receiving care started telling us about the kind of care they wanted to provide and receive. And it mirrors lots of other movements in other parts of the UK, and in other parts of the world, where we're starting to shift away from that model of care where doctor knows best, sometimes called that paternalistic model of care, to including people and patients much more in the decisions about their care, so described as person-centered care. And it includes being able to make decisions with patients rather than imposing care on them, and lots of other things that go around that.
And so how is it going? It's been 2016, 2017, I think it came into...
Yeah, I think it's going very well. I often say to people, it's not a hard sell, really. So in that way, it's quite straightforward. When you describe those principles of care, people who are interested in, people who are in our business, if you like, feel really comfortable about practicing in that way. So that part's not difficult. Sometimes, of course, we could be better around communication. Sometimes our own priorities and interests can get in the way. So we have to be really mindful about that and remember to keep up with those skills of sharing the decision and making the, if you like, the power balance in the relationship fairer. But on the whole, I think the bigger problem is more the system and the structures that we work in and how care is been designed that make it a bit more difficult to practice like that. So realistic medicine's going really well because it's been embraced across all the health boards in Scotland. It's part of delivery plans now of all the health boards in Scotland. And so we're beginning to get real traction around that more systematic part. It's a social movement, if you like. It's a big culture change. So it's not going to happen, not every element of it's going to be delivered overnight. But I think it's going well, yeah. And it's fun to be part of.
Because I think not equivalent, but a similar sort of movement in Wales was the prudent healthcare.
Yeah, it's really like prudent healthcare, yeah.
So the 4 principles of prudent healthcare: public and professionals are equal partners through co-production, care for those with the greatest health need first. This is the one I like: do only what is needed, do no harm, and reduced inappropriate variation through evidence-based approach. So that's very similar, I think, to what you're trying, isn't it?
It is. I think prudent healthcare was described as common sense. And that's often what people say about realistic medicine too. So, elements of that. And of course, I think prudent healthcare was part of the 1,000 Lives campaign in Wales, wasn't it? Choosing wisely, North American kind of aspects. I think in Italy they have slow health. These are conversations that are being had around the world. and for the reasons that we understand that, demand on health is rising. We want to make sure we're doing the right thing in a sensible way, and doing things that really matter for patients.
Listeners might remember that we had Sally Lewis, who's the head of Prudent Healthcare, episode 3.3 for the nerd. And so we had good chat about that. And I suppose I was interested in, so very similar, but there are always differences. And I wondered if you might describe how you think it was different. And I'll just say something to give you some time, because my impression of when I've been to Scotland and I've studied what Scotland has done when I worked in medication safety in NHS England nearly 9 years ago now, the one thing that I thought Scotland did differently at the time and always since is it's really, really good. They won't do anything without a patient participation. Everything that they do seems to be around patients. Would you agree, or is there something else that you think is different?
Well, I suppose we have a slightly different model, of course, of healthcare, as you know, in Scotland. We're one of the devolved nations, but we spend about half of our budget on healthcare. So, it's right up there with the most important thing we do. But we don't have quite the same commissioning relationship with healthcare providers. So, small nation, we've got these 14 territorial health boards, and some other special health boards. So that relationship's a bit different. We do very much have a culture and perhaps an ability, because of our size, of being close to patients and trying to include patients in everything that we do. And realistic medicine's no different. So we've had, for example, a citizens panel and a citizens jury informing us, when we share the principles, the ideas, coming back to us to tell us what matters to them. And perhaps some of that emerged from the early work that went on to deliver the Scottish, what was then called the Scottish Patient Safety Fellowship, now the Scottish Quality and Safety Fellowship. So perhaps you're right, it's very much becoming ingrained in our culture.
And you were also leaders in the UK, if not the world, around polypharmacy and deprescribing. I mean, the Scottish polypharmacy documents, I think you're on version 3. I teach every week, and that's where I send people. That's the app that I advise that people use. I mean, it's phenomenal. Is there a very close link between that and your part in realistic medicine?
Yeah, we're so lucky to work closely with our colleagues in that area in polypharmacy, and to some extent they've kind of led the way in not just recognizing what the challenges are, but as you say, giving very clear instructions, building that toolkit about how to deal with polypharmacy. And yet, of course, there's still much more to be done. So we're lucky to have that group on board, and I know they're very active in continued research in that area. But I suppose the question is, how do we mainstream that even more? How do we make sure that those polypharmacy reviews are taking place for people in the right places at the right times, really reliably? So still some work to be done there too.
Along those lines then, Catherine, one of my pleasures is every November I come up and chair the conference that we met, and I think I've done it the last 5 or 6 years on the bounce. And if you want to know what water is, don't ask a fish, isn't it? So it's a real pleasure to come up to Scotland and let them know how good they are, really, and how much the rest of us actually take on what they're leading the way with, how we use the resources, as Steve has said, the way we signpost, copy, share. And so again, I share it with the audience. There's usually about 300 in the audience, and they're looking at me a bit, really, and it's like a surprise to a lot of the audience. So it's always a nice thing to do, and it's genuine and it's meant.
Pharmacy First is the other one. What you've been doing in community pharmacy has been, way ahead of ahead of Wales, and certainly ahead of England. I guess, as you said, size helps, doesn't it? But you also need commitment and get the right people in the room, essentially, I guess.
Yes, I think that's true. So I've no concerns about the commitment of the health and care professionals that I've had the pleasure of working with now for more than 30 years. I'm relatively new, the last 2 years in my role in Scottish Government, and what's been really fantastic is to see exactly the same commitment in my civil service colleagues as I see in the professionals, the same values, the same desire to make a difference, but perhaps through a different mechanism, through a much more strategic, policy-driven approach. So yeah, it's been really interesting.
So the $1 million question is in terms of outcomes. Is it starting to show improved outcomes? And I suppose if I'm a patient in Scotland, what am I seeing differently?
Yeah, so I think that's a good question, and because it's not a simple strategy with standards and a measurement framework, I can't say to you that we've seen, X reduction in Y as a direct result of realistic medicine. We've had some evaluation work done, and of course they let us know, as you would imagine, that health and care is complex and messy, and attributing significant difference to realistic medicine alone, when there are so many, innovations coming along all the time, is hard to do. We are really interested in outcomes, and we've been working with Sally Lewis and others in the value-based health and care team to be much more specific about certain outcomes, particularly outcomes relating to patient reported own outcomes, what we call PROMs and PREMs. You'll know all about those. But in terms of the outcomes in realistic medicine, I think we're measuring that much more around the conversation and behaviours of boards and practitioners, and what we begin to see in the behaviours of patients too. So it's about encouraging certain practices within health and care, but also building that expectation in patients about what they should expect to be involved in, and the decision making and sharing and so on. And we definitely have good evidence around that.
Yeah.
So I think you have some evidence that's come out end of last year, which was part of the Eye Sympathy project. So Scotland, wasn't it, was part of other European countries and Ireland, and it looked specifically around polypharmacy and providing structured medication reviews. And so I know they've recently done an analysis of that, because we've been looking at it from the England point of view, and you had reduced medicines, reduced costs, you had good PROMs, as you said, patient reported outcome measures, and 91% of patients said that it helped their understanding in relation to medicine. So you had some hard points and you had some soft points. So I helped you out there on a good outcome.
Yes, well, I don't like to take credit for that and as being specific to the realistic medicine program, because Alpna Mayer and her team have been working on that to some extent, not independently, but I think they really deserve the credit for that rather than the realistic medicine team. But of course, well, first of all, I'm very happy to take it. So thanks, thanks for.
I'm picking up Scotland every day.
Exactly. Thanks for including us in that. But that's to some extent been a piece of work which really should be credited to that team.
Sure.
And we see the outcomes in the value-based healthcare work and how that's working. And I think we've got to do it, haven't we? Because you said Scotland spends over 50% of its budget on medicine, on healthcare. I think it's more in Wales, isn't it, Jamie? I think because we've sort of got less devolved responsibilities. So and I can't remember if I read it on your website, on the Realistic Medicine website, or if it was a rabbit hole I went down when I was researching, but a report from the World Health Organization saying 1/5 of all spending on healthcare in the world is on care that adds no value.
Yeah, I think that's from an OECD report, and we do
That's right,
quote
OECD, yes.
Yeah, we do quote it in the Chief Medical Officer's report, the Realistic Medicine report. So I think that figure's now out of date. So I've been talking about that for quite a while. 20% of our healthcare spend producing no beneficial outcomes for patients. Many people are telling me now that there's other data coming out that could be 30, 40, or even 50% for a variety of reasons, for complex reasons. But usually when we talk about that with my colleagues, there's no one in the room who doesn't want that extra 20 or 30% to be in their budget. We all want to be able to use that funding for something else. So it's how do we get there?
I think that was the bit that I took most from the Sally Lewis episode, when she gave us the evidence what they'd looked at inhalers for people with chronic obstructive pulmonary disease. But because they had the finance people in the room, they agreed that, hang on a minute, we'll take a share of that, okay, by reducing the number of inhalers that weren't providing any benefit. But we'll use some of that money to fund something that has actually got quite good evidence, which is pulmonary rehabilitation. And so I remember when we discussed it saying, well, that's exactly what you want, isn't it? But I'm sure it's hard to link that all together.
Yeah, I mean, that's a fantastic piece of work from the group who were looking at COPD in Wales. And I often use that as an example when I'm speaking to a range of folks, about realistic medicine, including finance directors who were obviously really keen to speak to and bring into the fold, if you like. So yeah, it's a great piece of work. It's complex, healthcare complex and complicated, and it's often difficult to move those budgets around. And Wales, I think, have invested very heavily in the structures that have been required to enable those kind of conversations, that kind of work to take place. So yes, we're stealing shamelessly many of the ideas from the value-based health and care team in Wales to do similar things in Scotland. Yeah.
It's lovely to hear the Welsh side of things as well, Catherine, but let's put it back to Scotland. Another one of your colleagues, and I think you presented some of this information, Professor Sharon Fletcher and her work. So one of the slides that you presented when I was up in Scotland in November was the drug portal to the world. Are you familiar? Do you know which?
Yeah, we might be talking about the loo. Yeah.
So there it is. So the work of Sharon and her colleagues, that's world leading, isn't it, on sustainability and water pollution with pharmaceuticals?
It is. So, of course, many nations, and Scotland no different, starting to really think very carefully as part of the value conversation about our impact of health on the environment and about sustainability. So the sustainability of the services that we have, but environmental sustainability too. Medicines is a really important part of that. As you know, we waste a lot of medicine, so they're prescribed and not taken. Some are not taken and then incinerated. I think about 10% of the medicines that we prescribe are incinerated and, of course, contribute to greenhouse gases and so on in that mechanism. Everything we take, or most of the stuff that goes in, goes out as well. So we want to make sure that people are only taking in things that are important and will make a difference to them. And we need to be mindful about how we deal with the increasing levels of different medicines and drugs that we see in the water table and elsewhere because they're excreted. So lots and lots of reasons not to use more drugs than we need. And Sharon's works, not only is Sharon's work fantastic, but also she presents it so well and with such great passion. So I'm sorry that she wasn't there to speak to her own slide. She has some very academic and detailed data-heavy slides, as well as the picture of two folks on the loo. But I'm not surprised that's the one you remember.
Very good.
Catherine, we're about 20 minutes in, and long-time listeners will be wondering how I've managed to not utter the word single organologist so far in the episode. And so my question to you is, how did a cardiologist end up, being the National Clinical Advisor for Realistic Medicine?
Yeah, it's a good question. Sometimes when I introduce myself as both, I have to not quite apologize, but ask for forgiveness about being a cardiology and ask people to let me off, because you can sometimes see the shutters come down immediately. I became interested, I think, in realistic medicine through being initially interested in the environment around me when I first started practicing. What I saw as a medical student and as a junior doctor, what I saw around safety and harm, particularly harms that I participated in, as we all did and probably still do. I was interested in this sort of systematic approach to harms, recognizing that no matter how hard we try as individuals, as you know, we will make mistakes. So how do we make the system safer to stop us from doing that? And I think it grew from there. When I became a consultant, I was, I think in the early days, a little bit frustrated, and many consultants find themselves in the same position. You kind of know your stuff, but there are lots of things that get in the way of delivering that stuff, whether that's waiting list or capacity to see people or funds or access or inequalities. And I didn't really know what to do about that. But I was really lucky to be accepted with a colleague, a consultant nurse, Catherine Labinjoh, onto the Scottish Patient Safety Programme. And we did a joint piece of work around heart failure through that programme, learned a lot. And that was really it. There's no looking back, there's no turning back. And most people who've been through that program say the same. It opens your eyes, you see the world differently, you see the possibilities, and you're excited about change. So
Yeah.
I guess that's how. And by not listening to my cardiology colleagues.
Well, I was going to say I can vouch for that because I met you at the British Geriatric Society, and the word realism and realistic medicine, I had about half an hour before I spoken to you, probably, broken ranks and given another cardiologist a very hard time and suggested that maybe they lived in the ideal world rather than the real world. But having listened to you, you were a breath of fresh air in relation to the holistic approach and the realistic side. So you've definitely, taken that forward. And so that's great.
Well, I wouldn't. It would be unfair of me to leave you with the idea that I'm critical of my colleagues who I think for the most part provide an absolutely terrific service in difficult circumstances. And most of us would want to see, if we had a problem with our heart, someone with a good deal of experience and
Absolutely.
skill around that. Of course, we also want them to treat us as a person, as an individual. We also want them to be familiar with the concepts now that most people have more than one thing wrong with them. So the majority of our patients suffer from what we describe as multimorbidity and experience polypharmacy and so on. So we want all of those other skills as well. It's a challenge.
Of
It's a
course.
challenge for any one individual to be able to be everything to all of those people. So I think we need to be clever and smarter and different about how we bring those requirements together.
I agree. And we might probably come back to this when we talk about the micro discussion in a bit.
Okay.
But yeah.
But you've passed the test. You've passed the Steve test, Catherine.
Well,
I know.
and that leadership training and politics, you've played a straight back there. Absolutely. Nothing to see here.
Nothing to see here.
Steve turned up at the conference prepared to hate you, and he was proved wrong.
No. I should defend myself because I do defend myself sometimes when everything that you've said, I agree with, and I have said this on previous episodes. Look, we all have our own biases, don't we? But you have to remember that my population of patients are working most of the people I see are between 70 and 95. So I've already got all these biases, the same biases that somebody who only sees people between the ages of 45 and 65 who needs a stent. We've all got those biases, and I realize that. And I guess that's where, if you see lots of the same thing, and there for me, I see lots of what I think could be improved upon in the holistic multimorbidity. So yeah, like you say, we need specialists, of course we do. We need generalists, then we need both to understand each other's side of view, with the patient in the middle, who essentially is the person we should most be listening to. I suppose that's the way I would cage it.
Yes, I completely agree. And of course, times are changing greatly for those who have a special interest in a single organ pathology. When I was a house officer, our coronary care unit didn't admit patients over the age of 65.
Wow,
Now,
yeah.
cardiologists are seeing the same patients as you are. So
Yes.
our coronary care unit has patients in it who are in their 80s, and they all have, multimorbidity. Single organ pathology is rare.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Okay. Well, I'm sure we'll come back to this later on. Catherine, I'm sure you know that there are 3 additional pleasures of coming onto the Oral Apothecary as a guest. The first one is quite simply, what is your desert island drug?
Yeah, well, I mean, that was hard, I have to say.
Good.
Very hard. And I thought, I've thought a little bit about it. And, obviously as a cardiologist, or should I choose one of those drugs proven to make you live longer? Very tempted to choose frusemide because it's one of those drugs that definitely makes you feel better.
Yeah.
Did you discuss it with anybody, Catherine?
Well, I'll tell you about that. Yes,
Okay.
a little bit. Not so much discuss, but share the idea.
It's the dog, isn't it? You've chatted to
Yes,
the dog.
Martha.
Martha.
Yeah. She's the smartest member of the family. Yeah. Yes. So thought about vaccines and so on, but I'm not allowed to give those. I think those are not drugs. But anyway, I came down to antibiotics. An antibiotic for a couple of reasons. One relates to that story of making a mistake that I told you about earlier, about why did you become interested in this? And it's because of the drug vancomycin, which we use a lot in cardiology. So we use it a lot in the treatment of heart infections, of endocarditis. I spent a lot of time and making up and giving vancomycin. But the very first time I made it up and gave it very quickly.
Aha. I know what you're going to say. Go on.
I think I do too.
I learned about, I think, what was then called red man syndrome. I can't remember what it's called now. It's got a different name. And it was a very, very, powerful experience. There's a background to why that happened, all the human factor stuff that you can imagine, being new, having it laid out, someone shouting at you, hurry up, we need the patient for the pacemaker, da 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 da. I wasn't a cardiologist then, but I happened to be working in cardiology. And lo and behold, I gave a drug to a patient too quickly, and they suffered an adverse reaction. Now, horrifying, but they were okay. I apologized, actually, as it happens. Some years before duty of candor became mandatory, I just said, I'm really sorry, I've done this. And that's why you feel like this, and you're going to get better. And they went for the pacemaker. I got not into trouble for giving the drug quickly, but I did get into trouble for admitting it, which was quite interesting.
Really? What year was this?
1993.
Okay, yeah.
It's all in the book, Catherine. Oops.
Yeah, exactly.
Why things go wrong.
I did feel deeply ashamed about it. And so I didn't tell anyone, my friends, my partner, my family. It was so shaming to have, done this terrible thing. So vancomycin, every time I see it, still have that little memory of it. And I guess the other reason is I was thinking about all the great things antibiotics do, of course, and personally, my son as a baby had neonatal sepsis, had fantastic care within the NHS. And I remember that confidence, even though it was terrifying, thinking, this is going to be okay. These people are looking after him really well. He's going to get some antibiotics. He's going to get better. And he did. I mean, I hardly think about it now, but actually that would have been a life-changing experience for us without those. So bizarrely, I'm going to choose vancomycin. It reminds me of that adverse experience. It reminds me of my son, and also my daughter is now working professionally in the policy area of antimicrobial resistance. And I think if I didn't choose an antimicrobial and plug antimicrobial resistance, she'd never forgive me. I know it's talked about in this podcast previously.
Yeah, several times. Very good.
So
very heartfelt.
A plug for that. It connects with most of the people that I feel that are important to me. So that's why.
And you're not alone. I think we had a few people, haven't we? Who've talked about a dispensing error being a memorable drug. And funny enough, when we were shamelessly trying to tout for business at the conference and trying to explain what we mean to Europeans who've never heard of desert island drugs, we want a drug. And so I said to quite a few people, maybe tell us what your first dispensing error was, and quite a few people went pale and said, "I'm not going to talk about that." But I think every healthcare professional remembers their first mistake. Probably more than their first. They remember all of their mistakes, and also you described there the concept of the second victim as well, didn't you? Which is you, as a healthcare professional who's made an error, probably as a result of systems error. And yet dealing with the guilt and the trauma of that as well.
Contributory factors everywhere, Catherine, on that one.
That was the early 90s. We were all working in the early 90s. So that is very, very heartfelt and very well thought out. So you've smashed it out of the park.
Before we move on, Steve, let me I'm just checking my memory now.
Okay,
so
go on.
Vancomycin, and there was a pharmaceutical thing at play here as well, wasn't it? Because you used to give the injection orally. Am I correct in that one? Is that
you can use vancomycin injection orally? Yes, for Clostridium difficile infections in the gut. But what Catherine's described, as she rightly said, is known as red man or red woman syndrome, it might be now, where you get a massive histamine release if you give it too quickly. And it's only if you give it too quickly. I've seen it happen as well several times in the 90s, Catherine. So, yeah.
But it was one of those... So I get it. It was one of those pharmaceutical preps where, as a pharmacist, if you knew those few things about it, you could walk round...
You could pass your Oski?
Yeah, you could walk round, sort of shoulders back, thinking, yeah, I know stuff.
Well, that was obviously only in Bridgend. In Bart's Hospital, mate, in London, you needed to know a lot more than that, let me tell you. Right, come on, we're only joshing. So, Catherine, you've smashed it out of the park there, definitely. So the second thing is a song for the Spotify Oral Apothecary playlist. So what would you like to offer us?
Oh, well, I mean, that's even worse. I mean, what a question. A song for your career. Music, it's important to me. I enjoy it, although I don't really connect it to my career or my profession that much. But um, I'll tell you a story because it's about
Yeah, we
stories,
like a
isn't it?
story.
I met my future husband, a little bit before I graduated, but we started dating within a week of me starting as a junior doctor. So I guess my romantic life and married life have run entirely in parallel with my professional life as a doctor. And when we met, as one did in the 90s, you might remember this also, Steve. One of the things you used to do was, go around to someone's flat and look at their record collection because people had
Yeah,
records.
I know, yeah.
And you could tell what your future might be together by how much overlap you had in your records. And we had none. We didn't have a single,
Don't judge a book by its cover and all that.
not a single record in common, except that
Oh,
he
here we
had
go.
actually on CD, which I thought
Early
was very
day,
foolish.
early adopter.
I did not have a CD player then. Um, he had Let It Bleed by the Rolling Stones, and one of the tracks on that album is called You Can't Always Get What You Want. So maybe that is a good theme for someone who works in healthcare. I knew that song from its inclusion in The Big Chill. It's a fantastic funeral scene in an 80s movie. And I'd also enjoyed playing it as a medical student on a Fisher-Price single octave keyboard in the pediatric playroom. It's a great track.
Well, let me stop you there, Catherine. If you
Yeah.
listen to the Tony Avery episode, he came on with his guitar and played his. So
Well, I could if you like. Yeah.
Well, it's still got the Fisher Price single keyboard.
Well, now that I'm a consultant, I'm pleased to say I've actually got a piano. So just showing off.
It's quite a
But
good
it
anthem for realistic medicines as well, isn't it? You
it's
can't always
quite-
get what you want.
But if you try, sometime you might find you get what you need, and I think that's the important point: getting what you need. So so I'm gonna choose that. It's a great track anyway. Thousands in my life that I've enjoyed, but yeah.
Wow. I mean, you've really given this some serious thought. I mean, very impressive. Very impressive. Okay, so we'll definitely take that. So the third thing then is a book for the Oral Apothecary Library. What would you like to give us?
Oh, well, this is a different story altogether. I don't really love non-fiction. I'm the opposite to you, Steve. I can't really be bothered with people's biographies. They're not really,
No, that's Jamie, yeah.
I can't, I'm really interested, and I often flick through and in a sort of slightly non-committed way, many of the great books that people have written about medicine and how we practice medicine, the sort of almost the self-help thing, or the manuals or the essays. But I'm going to choose a book of fiction.
Cool, yeah. Lots of people have picked fiction.
And it's nothing to do with medicine
No, it doesn't have to be.
or medicines. But I read it over the last few years and I really enjoyed it. So it's a book called There, There. It's by a Native American author called Tommy Orange. I think it was his first book.
Okay.
It's a good read. And for someone who doesn't love nonfiction, it has a very interesting essay about Native American life and the sort of the evolution from colonialization, which I never thought I would enjoy, but I did. And then it goes on to talk about really, really interesting things to me anyway. Maybe it was enlightening for me, thinking about identity and place and culture and how that all feeds into who we are and how we behave. So yeah, it's called There, There by Tommy Orange. It's just a good read.
Maybe that plays to what you said about, your interest in that kind of holistic side to medicine. I think you've kind of captured it by your own description there. For the record, it's Jamie that does all the massive reading. I'm not that bright. I like to listen. I listen to podcasts mainly. So
And I'm a big non-fiction and comic reader, so.
So think back, Catherine, when you were reading it. Let's just. Do you think you ever took any paracetamol or anything while you were reading it? So that we can link it that way, I'm sure.
no, I'm going.
Well, it does, of course, describe within it some of the social problems for that group, particularly around urbanization. So drugs and alcohol do play a part, don't worry.
Okay,
Here we are.
And indeed, I think one of the characters actually has fetal alcohol syndrome. I've never heard, that someone with that being affected with that actually being given a voice and being someone whose perspective you might understand in a novel. So interesting. And I probably did have some paracetamol, yeah.
There by Tommy Orange makes it into the Oral Apothecary Library.
And your three choices, Catherine, I thank you for considering them. They're exactly, when we first started this 3 years ago, that is the type of emotional connection that we were looking for. So thank you for that. They're memorable, and we will refer to them many, many times in the future. Okay, our micro discussion next. I think I know where this might be going. Look at an article in the New Statesman by Dr. Phil Whitaker. It's about a patient, Ted, that Phil has seen and writes up. Do you recognise Ted, first of all, Catherine?
Yeah, I know Ted.
Yeah.
You know Ted too.
Yeah.
Most of us have Ted in our families. Well, maybe we're lucky enough to have that. So yes, of course. And maybe there's a bit of Ted in all of us too. So I thought it was a really lovely piece.
To describe Ted, so he's someone who medicines are going up, symptoms aren't going down, gradually feeling worse, getting fed up, hopeless, and then decides to stop taking his medicines. And
he's lonely.
The link is as well that he's lonely.
Yeah.
Decides to stop taking his medicines, and apart from going back on to one, obviously starts to feel a lot better. And then he relates it to his own life, doesn't he, where he managed a care home and realised that he used to see that in his residents as well.
And he's in a triangle of care, isn't he, between his cardiologist, who's still searching for something, and his GP, who is starting to get to know him.
I think the killer sentence that's pulled out, isn't it, is that he says, Ted himself apparently says to Phil, who's the GP, everything's decided on hundreds, thousands of people, he told me, an astute summary of clinical trial design. That can't possibly tell you what to do for any individual. There's only one Ted, after all. And so, it gets to the nuts and bolts, I guess, and why we picked it, what we knew we were going to talk about. And I suppose we've already touched on this, and it is that, and when Tony Avery was on, we talked about the Chief Medical Officer in England's report, and you've already mentioned it, Catherine, is how do we get people who are practicing medicine they realise, of course they do, but to get better and feel more confident in multimorbidity, because this is essentially what we've got here, isn't it? And therefore, just adding all the time when clearly he's already decided that they don't help him and he's probably having problems of himself. I mean, I see these people talk to these people every week, and so it's almost opportune that at the same time as we picked it, somebody did quite an in-depth qualitative analysis. I think Jamie might have sent you the editorial, which is in one of my favourite journals, which is quite highbrow, but it's the British, the BMJ Quality and Safety. And it actually is a piece about how do we get the specialist and the generalist and the patient to try to work better in heart failure, which is what this case was actually at. I don't know if you had a look at that, or if Jamie or Gimmo had any reflections on that piece in relation to this.
Yes, well, as you would expect, Steve, I did my homework. You sent it to me, I read it.
Very good.
As
I said earlier, it's field work, Catherine. We don't want to call it homework. It's field work.
Full commitment here. So, I had to remind myself of who said this, but I think it's the guy who designed the framing studies. The biggest probably ever epidemiological study into heart disease in the USA, which ran, I mean, I think they're still producing
running.
framing and data exactly since I think the late 40s, and he said the patient is more than the organ of your choice, and he was aware of that even then. So I think that's an important thing to just to hold at the center of this. And of course, TED is more than his heart failure diagnosis. That said, I completely sympathize with the cardiologist who feels tasked to make a difference in that area, who's been asked a question, presumably by his GP, and wants to make a difference where they can. And that time when you transition away from all that you can do as a specialist to maybe what you should do to maybe what you should stop doing, it's a kind of I hate to use that expression, but it's a bit of a journey. So it's difficult.
Because the bit I liked about the paper was a phrase that I use a lot, which is in quality improvement, which is work as imagined versus work as actually done.
Yeah.
And so you've got, say 6 different clinicians looking after a patient, all with a different fantasy of what the others are doing. and that's why part of quality improvement is about bringing people together to share their experiences of what they all do.
Yeah, so I think the work as imagined is often driven, isn't it, by the counsel of perfection and by guidelines and evidence-based medicine and so on. But I think we're beginning to make a big difference in that. For example, NICE have published guidelines which are adopted by SIGN, also the Scottish Intercollegiate Guideline Network, around shared decision making. And last year we had a conference with the SIGN Guidelines Network about how can we ensure that those important personalized components and shared decision making considerations are sort of front and center of every guideline that's produced, so that we recognize the guideline has to evaluate that evidence that Ted mentioned for, I can't remember if it was 10,000 people or whatever, but it needs to be in its implementation personalized for TED. And I think that's the challenge. And then with the other paper that you described about, I think it was about managing what we call heart failure with preserved ejection fraction, a certain kind of heart failure often associated with being older and multi-morbidity. There's a very clear description there that just knowing what drug to give or the name of the condition or whatever is not enough. We need really clever and coordinated care that's designed around patients. And of course, most of our care is not designed around patients. The NHS and its infrastructure was designed around how it was easy for us to deliver care. And we've been really thoughtful about that in Scotland with our Getting It Right for Everyone programme, which is piloting now and due to launch in the summer next year, looking at how can we focus design and delivery of services around patients in the communities where they are and build those services with massive input from patients.
Yeah, we'll put the link in the show notes, but we should just we always try to give due acknowledgement. So this is a team: Rosalie Brooman-White, Thomas Blakeman, Duncan McNabb, and Christy Deaton. And as you say, it's about informing understanding of coordination of care for patients with heart failure with preserved ejection fraction. And they come up with this lovely phrase, don't they? And they say, seeking a unicorn, the accessible, time-rich specialist generalists. Did you like that? Did you see that?
Oh, I recognise it. It's just like going to work every day, that description.
Yeah.
Can I take us back to basics for a minute on this one and read something out from John Lorna and his piece that he did a few months ago, How I Walked Around Wales with Heart Failure. Okay? And so I'll read it out. And it takes us right back to a fundamental, which I just wanted to check with you, Catherine. 7 years ago, a consultant cardiologist stood at the end of my hospital bed with 5 or 6 people he never introduced, and he told me I had severe heart failure. 7 years on, I just finished circumnavigating the whole of Wales on foot. I did it in around 80 stages, a total of 1,000 miles across some of the most rugged coastal and hill terrain in Britain. He goes on to say that he tells this story for several reasons. Firstly, I want to remind everyone that doctors still break bad news to patients in the crassest ways without either privacy or hope, as if they're making an educational video about all the mistakes you can make. Secondly, he wants to emphasise what a stigmatising and outdated term heart failure is. So I've heard lots of the pharmacists that are now part of the multidisciplinary setup for heart failure, and they're scattered around the UK, some more vocal than others. I've heard them say that it's not a great term and they don't use it. Is that something that you recognise?
I do. So in our service in Forth Valley, in fact, when I joined it as a consultant in 2007, the term heart failure wasn't used. We had a heart function clinic, not a heart failure clinic. I've kind of gone back to using it though, because heart failure is often in the news. It's well publicised. If you want to have information about what your condition is, that's actually the term under which you're going to find it. So I usually introduce it to patients with an apology, saying, "This is what it's called," and explain, and perhaps hopefully I'm a bit less crass and a little bit more hopeful when I do it. But yeah, the language is really difficult. But changing those recognised terms is tough as well. So I've stuck with it.
I can remember my dad telling me when he was told he had heart failure, and then he said he didn't hear anything for the next 20 minutes of what was told, because all he heard was the word was "my heart is failing," or and it just, you didn't hear a thing after that.
So John goes on to do another training piece, which I just want to do this as well, because I think it links to what we're talking about with prudent healthcare and realistic medicine and patient-centred care. There's a teaching exercise I've done a few times with medical trainees based on my own story. I first present a slide showing the medical history of Mr. A in bullet points. He's had a heart attack at 39, had a series of pulmonary emboli in his 40s, was fitted with a pacemaker for complete heart block in his 60s, has several other recorded conditions including arthritis in his knees, tinnitus, is taking 5 medicines. I ask them what image they have of this man. Frail, they reply, or occasionally heart sink. The general opinion is that he's not likely to be around for much longer. The next slide gives a narrative account of Mr. B, a man of the same age, married with 2 adult children, who still works almost full-time professionally, quite often travels internationally to do so, and is a keen long-distance walker. I ask them to explain how the 2 men have come to be so different. The reasons the trainees offer include lifestyle factors such as smoking and obesity. Occasionally, someone speculates that the slides may relate to the same person, but even then they don't anticipate the punchline, because they're him. But that way that we talked right at the start of the podcast about how important language is, and just seeing that person as the case rather than, and I think in the realistic medicines report it mentions that it's biographical as well, isn't it?
Yeah,
that realistic medicine is about being biographical as well.
Exactly, yeah. So when I am participating in multidisciplinary team meetings about patients, I hear much more of the second description now than I hear of the first, and that's because I hopefully we are better at making sure that it's possible to make good decisions about patients with the scientific factual evidence, and still incorporate that much more holistic, person-centered factors. I suppose we were trained to avoid bias, so we stripped away a lot of the fluffy stuff, and that was seen to be a distraction, maybe an adverse influence. Maybe people would feel that one person, if described in that way, deserved input or care more than another. So I think it was with the best of intentions. But of course, you're right, all of those things, what do you like to do, who matters to you, what's coming up that's important in your schedule, what's your dog called, all of that stuff makes a difference, and it also makes the practice of medicine really enjoyable as well. So I like to think we're getting much better at that.
Okay, just complete the story. Look, John went on to finish his walk around Wales and raised thousands of pounds for the heart charity Pumping Marvellous. So thanks, John, if you're listening. I really enjoy your pieces in the BMJ. A big thank you to Catherine for joining us on the Oral Apothecary, for sharing her stories, her desert island drug, and her book for the Oral Apothecary Library. Coming up next time, we'll be joined by Dr. Esther Clift. Esther is a physiotherapist, a consultant practitioner in acute frailty based on the Isle of Wight. Clinically, she leads an acute frailty team in an emergency department supporting older people using a home-first strategy. Join us next time on the Oral Apothecary. You can contact us via Twitter at Oral Apothecary. We're on LinkedIn. You can email us at oralapothecarypod@gmail.com. Don't forget the website, theoralapothecary.com. Gimmo now with a final ingredient.
Okay, so thanks, Catherine. That was great. I really enjoyed that. So we talked a few weeks ago about how drones might speed up the delivery of life-saving medications such as naloxone and EpiPens. But what would we do if we're in a place where drones can't reach? And in fact, what if you're an astronaut on the International Space Station? What would you do then? Well, the obvious answer is keep a supply of EpiPens on board. And until recently, that was the obvious answer and what NASA did. That is, until a group of curious students from St. Bother Andre Elementary School asked the question, do EpiPens work in space? The students were lucky enough to have their question accepted as a NASA experiment, and so several EpiPens were sent into space and analysed to see what actually happened to the contents. The results were surprising. The samples that were analysed on return to Earth showed no epinephrine was to be found. What had happened to it? Well, it turns out the culprit is cosmic radiation. This transforms epinephrine into the extremely poisonous benzoic acid derivative, making the EpiPen unusable. This discovery was groundbreaking. NASA had no idea. And the discovery obviously not only has implications for EpiPen, but other medicines and chemicals as well. So well done to the children of St. Bother Andre Elementary School. But perhaps the real lesson here isn't about the power of cosmic radiation. It's about the power of curiosity and the childlike ability to ask stupid questions. As Paul Meyer, professor at the University of Ottawa's Faculty of Science, said, kids are natural scientists. They're curious and ask questions. We adults just need to facilitate their participation in the scientific process. And maybe as adults, we need to act more like children ourselves.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Oral Apothecary podcast. Warning, always enjoy with an alcoholic drink, especially if operating machinery.
This episode of the Oral Apothecary is sponsored by jamiehayes.co.uk.